Good evening, everybody. I'm Dr. Rick Lehman in St. Louis at the U.S. Center for Sports Medicine, and we're here tonight in your corner with CORA 9/29/2020. The St. Louis Cardinals are in the playoffs, which is a good thing, and we're going to talk about concussions tonight. And I just want our staff to introduce themselves. So we'll start with my buddy Bryan Anderson. Bryan.
Hey everybody, Bryan Anderson. I am the team leader for CORA Physical Therapy's Active Tracks program, which is our sports medicine and community outreach division. I've been a certified athletic trainer since 2004 now.
Dr. McMarlin.
Hi, I'm Andrew McMarlin. I'm a sports medicine physician, original background in rural and inner city family medicine. Prior to my ortho sports fellowship, had been a long time ago a serious athlete, trying to still be somewhat of an athlete, and trying to keep up to date with concussion. Things change all the time, so it's exciting. Got into it when I was team physician for DC United, and had a few people who had to retire early. So it's kind of concussion management and is near and dear to my heart.
Dr. Upshaw.
So I was a pediatrician working in the pediatric emergency department for about 15 years, and also was had been an athlete, still try to be an athlete at Emory, and the Braves are also in the playoffs, I'd like to add. But and then went back and did a sports medicine fellowship, and joined Dr. McMarlin's practice, where I see both adults and kids, but obviously with my background in pediatrics, have a special interest in pediatric concussions.
That's awesome. Well, first of all, thank you for all joining us tonight. This is a hot topic. You know, as I think we all know, last year there were somewhere between 2 and 3 million documented sports-related concussions, which is crazy. And traumatic brain injury is the #1 cause of sports-related deaths. So it's obviously a very, very important topic. And I think to start off, Dr. McMarlin, why don't you give us kind of the first question? And what we want to know is, what is a concussion? What are we talking about? And what is the pathophysiology of a concussion? What happens?
Yeah, so it's a concussion is a really complex kind of neurometabolic injury. It's not just specifically necessarily an impact injury, but it is induced by trauma. It can be from direct or indirect forces to the head. And it's not necessarily a single shot. It can be a cumulative amount of traumas. So it's really a disturbance of brain function at the kind of the neurometabolic dysfunction level, as opposed to a structural injury. And so it results in this really constellation of kind of physical and cognitive, emotional, and sleep-related symptoms. And it's definitely not defined by loss of consciousness, which I think was still maybe a misunderstanding, but that for a long time, that has, I think, been misunderstood widely. But and the symptoms can last for minutes, hours, days, weeks, and we see people with who've come in with symptoms for months and even years. So again, a complex, really pathophysiologic process.
Thank you. Dr. Upshaw, this is going to be a little bit unfair, but could you give us a clinical presentation? And obviously, every concussion is different and every clinical presentation is different, but give us your thoughts on maybe a typical clinical presentation, maybe some outliers, and what you see in your practice.
Well, like you said, everyone is a little bit different, and I had an attending a fellowship that used to always tell patients they're all like snowflakes. Each one is different, and each one in the same person is different. But typically, someone will have what they describe as, they'll have some sort of trauma, and then they'll afterwards describe what sort of just being in a fog. And we see this frequently, where they say, I'm in a fog, I just can't process things. Frequently, they'll have a headache, maybe neck pain. And then just describe just kind of an overall fatigue, wanting to sleep all the time, at least early on. They'll frequently have problems with sensitivity to light or sensitivity to noise. So generally that's sort of how we see them kind of early in the presentation. They will also complain of dizziness, sometimes nausea, sometimes maybe even vomit. And then from there, it depends a lot on the individual, with different factors. What's their comorbidities? I think that people with that kind of underlying history of anxiety and depression have what I call a sensitive brain. And they seem to frequently sometimes have a little bit more trouble bouncing back. People with multiple concussions in their history sometimes will have a harder time bouncing back. And then you mentioned pediatrics earlier on. So young children, for some reason, sometimes struggle a little bit more. For some reason, at least in some studies, females tend to have a more protracted course.
Great, thank you. Bryan, you're up, buddy. So you're on the sidelines. You expect, you see a hit. You expect that the running back may have suffered a concussion. Kind of go over your physical exam on the sideline. Explain the Scat, SCAT5, and what are you looking for? Explain, kind of give us the crux of what we need to know when we're on that sideline and we're doing that initial exam. The athlete comes off the field. Kind of take us from A to Z.
Okay, yeah. One of the biggest things we look at with concussion, one of the greatest things we can see is actually if we can actually see the play, and it's not always possible, right? But maybe if we can see the hit or see the quarterback get sacked and his head kind of bounce around, to know if that's actually a concussion or what we're dealing with. On field and kind of sideline differ. If a person's down and you get out onto the field, obviously first thing we're looking for is all of our red flags: severe neck pain, insensitivity, severe vomiting, loss of consciousness, all that stuff kind of shows us that maybe something more serious going on that we may need to involve EMS with. When we get to the sidelines, we're generally kind of doing the same thing. We're just taking a little bit more time to figure things out, right? So again, you brought up the Scat5. The whole point of the Scat5 sideline exam is basically to determine if that patient needs transported or not. So it goes through a quick Glasgow coma, goes through a quick symptom checklist, a quick cervical checklist, and then maybe a couple memory and neuro tests as well. As far as my sideline evaluation, I'm going to do a Scat5 sideline evaluation. I'm going to do a cranial nerve evaluation. And then, depending on what the symptoms are, we may look a little bit more into some of those symptoms and see if we can figure something else out. So again, we're trying to determine that plan of care. So whether you need to go to the ER, whether you need to follow up with, primary care or a specialist on Monday if it's a Friday night football game, and really determine that.
So help me out here. Athlete comes off the field. They're dizzy, maybe they're a little sick to their stomach, they're in a fog, just like Dr. Upshaw said, they got a little bit of a headache. How are you going to decide when to transport that athlete, or what's your next step?
So again, we're going to do that evaluation, and the first thing you look at is these red flags. So some of the things, just in my experience, I've seen with concussions, you either tend to see severe symptoms right away or symptoms that degrade rapidly. So they may come off the sidelines and say, I'm a little dizzy or a little sensitive to light. And then all of a sudden their balance is affected. All of a sudden they're vomiting on the sidelines. They can't stand up. So again, that's transport situation. Or one very severe symptom I would transport. The one golden rule that's always transportable to me is loss of consciousness for any point of time. Has always been my policy as an athletic trainer. Even if it's for a second, still that's traumatic enough for me to say that there's something potentially more serious going on here. So yeah, it's really difficult. And this is kind of the tough part for an athletic trainer or anybody seeing these injuries for the first time is, what's really the threshold to call this a concussion, right? Because I guarantee you, if you went out and put a helmet on and ran into somebody else right now, you'd probably have a headache, right? Or some type of symptom. So again, what's the threshold? And really, how many symptoms do you need to consider something a concussion? Because again, in my experience, just one, right? So you need a history or, you know, some type of traumatic event, and at least one symptom to follow. So you look at number of symptoms, you look at severity of symptoms, and kind of go from there. With the current climate of concussions, it's very easy to err very conservatively. So I don't take a lot of chances with concussions. And if I always tell my students, I taught in a university for a little bit, if in your mind you can connect the dots, then treat it as a concussion.
Thank you. So Dr. Upshaw, to kind of expand on that a little bit, athlete has quote unquote a concussion, he's a trainer. Trainer says you're done, you need to go see Dr. Upshaw tomorrow. Please explain kind of your, taking it from there, please explain your exam and what are the giveaways and how do you make that diagnosis of I've just had a headache or I ran into the wall with this football helmet on versus I have a true concussion and I might have a sequela of post-concussion syndrome?
Well, I think it can be a judgment call. And like he said, sometimes a good solid hit, it stands to reason that you would have a headache. But I think that when it's something more than just a headache, when you're seeing more symptoms, so on the Scat, they have a whole list of symptoms, and we use that in our office and have the patients go through that. And when I'm seeing 10, 12, 30 of those symptoms, it certainly makes me feel like they have a concussion. To piggyback on something that he was saying, as someone who did pediatric ER for 15 years, I would say vomiting was always a symptom that made me very nervous. It made me kind of pull the trigger when I was seeing those patients in the ER to get a CAT scan. But you know, my exam, what I'm looking for is balance is a big one. We look very closely at their ocular movements and their vestibular ocular. Do they have nystagmus? Do they have saccades? And we sort of put them through a test like through that. We can almost basically repeat the Scat and then kind of hone in on the on vestibular ocular function as well. And then I check reaction time. So I have like a little hockey stick that I drop and have them catch and just see how quick they are.
I like that. Can you explain the Scat a little bit more thoroughly for people that are listening, mostly physical therapists, some orthopedic surgeons, exactly what are the testing, what are the questions, what is the Scat 5 or the Scat 3?
Well, it's basically I don't know how you want to say. It's basically a conglomeration of tests. So it starts with a mini mental status exam. You know, where are you? What day is it? And then you go through a battery of other tests. So for example, you'll give them words and have them repeat it back to you to check their short-term memory. You'll do that 3 times. And then later in the exam, ask them again what those words were to test more long-term memory. You'll have them do digital memory where you give them numbers and they have to give them to you backwards. And so that's looking sort of more at your ability to concentrate. You have them do balance tests, and there's a few different ways to do it, but the way we usually do it is have them sort of stand for 20 seconds with their eyes closed and then on one foot and then with tandem feet. And you're basically looking to see, can they do it? How many errors do they have? The error being they have to reach for support, or how much sway do they have? And basically just sort of looking at the different domains of concussion and what does that athlete, or what deficits does the athlete seem to have?
Thank you. So Dr. McMarlin, this kind of pertains to the next step, and the next step is included the athletes had a concussion, maybe a series of concussions. And I think as an orthopedic surgeon, we're always taught the MRI is going to be negative, maybe the CT is going to be negative. So kind of go through your testing protocol. You do neuropsych testing, you order CT scans routinely. What tests should we get? Do you get x-rays? Where do we go after the exam?
So I look at it with kind of two different ways. There's the immediate, like if you're on the sideline looking, as Bryan and Dr. Upshaw were saying, do you have red flags? I mean, if someone is having significant difficulty with balance, particularly if that's getting worse, if they have a headache and that's getting worse, if they have amnesia, like they're having difficulty with memory that continues beyond the 30 seconds or a minute, I'm more concerned about getting them in to the ER to get a head CT, worried about kind of intracranial bleed. And there's a lot of those different red flags. And in the office, typically it's a little bit kind of different story because we're out past the 24 hours where we're worried about someone having a big brain hemorrhage. So we're trying to identify, do they have vestibular dysfunction? So is this something that they're going to benefit from getting specific post-concussion vestibular PT? Do they have an ocular motor function? So do we set them up with a therapist who can do the kind of vision therapy, which sometimes is helpful, and really get an assessment of how limited they are and what their total symptom load is to see how likely they are to tolerate cognitive work. I mean, 20 years ago, you'd tell people to go into a dark room and stay there, and all the recent research is that doesn't really work very well, particularly for athletes, as far as the not doing anything side. But we still really respect the need for cognitive rest, and there's kind of determining how much work someone is able to do this, like scholastically getting there, and usually we'll have someone do a progressive kind of return to reading and cognitive work. If someone is like an industrial athlete, like we have in this area, we have a lot of people who work for Boeing or a couple of different car companies like Sprinter vans for Mercedes, where they're doing a lot of kind of manual work and figuring out, are they going to be able to tolerate that, particularly if they're in a funny position, looking up, twisted over. So if their vestibular system is really off, they may not be able to function in some of those industrial athlete jobs. So figuring out what those different deficits are and going along a pathway to try to help with those. And primarily going through the process of making sure they have enough mental recovery, which a lot of that's making sure they get a good night's sleep. So it's a lot of our understanding of when people get better is during sleep. And so maximizing sleep is important. And if someone develops a sleep disorder, which is really common as well, there's lifestyle changes and sleep hygiene, but there's also medical management of that. But sometimes there's as simple as some GI management. If someone with our metabolism that goes up so much in our brain after an injury, if you have not, like Dr. Upshaw was talking about the nausea, if someone has enough nausea or just a decreased appetite where they're not eating, they're not going to have the energy for their brain to make a good recovery. So it's a lot of that initial exam is identifying which of those different symptoms and signs that we pull out are going to affect their recovery, and depending on which pathway looks most appropriate, we go that direction. And so sometimes we see that in the acute phase, but a lot of the time we'll see people 2 years after a motor vehicle accident, they still have some of these injuries that they're still there, but if they never had them treated appropriately, some people can still have improvement a year out, 2 years out, which is kind of surprising.
Thank you. Well, Bryan, when can an athlete, and again, I know, like Dr. Upshaw said, every concussion is like a snowflake. Everyone's a little different, but what are your parameters for letting that athlete go back and play? Can they go back the same day, the same game? Do they need to take a week? What are your parameters to say, all right, that D-back can go return to play?
So never in the same day. If it's been evaluated or assessed as a concussion, absolutely never in the same day. And I would say really challenging in under 2 weeks. I mean, again, unless they got a very minor concussion, symptoms clear in 5 minutes, and they're able to do their required testing and protocol before they can get back. But again, with the way, specifically the way CORA has their testing set up, and most of the states have their testing set up, it's virtually impossible for an athlete to have a concussion on a Friday night and return to play the next Friday night. To me, we need to have absolutely 100% symptom-free. And not only that, but with some type of neurocognitive testing. So return to some type of baseline with a Scat 5 or impact or one of the other 100 tests that are out there at this point. And then they need to properly pass a graded return to play protocol, a 6-step return to play protocol that needs to be tailored. Dr. McMarlin hit on it. The cognitive loads and vestibular loads and even neuromuscular and exertional loads, even when we look at athletes in the same sport, the cognitive load for an offensive lineman and a quarterback are completely different as far as snap decision making and being able to do these things. So I mean, I need to see them do a pretty substantial and a pretty good graded return to play and a final test to kind of make sure that they're there before I'm confident to say that you're not at risk. Yeah, I mean, and again, they're always going to be at risk when we talk about returning somebody within several weeks of concussion. But that's, again, gives me the most confidence.
Thank you. So Dr. Upshaw, what predisposes these athletes to concussion? Is there something that you could say, wow, this would be something that would predispose an athlete either to the index concussion or to subsequent concussion or repeated concussions? Is there something we should be looking for? And is there anything we can identify that would predispose these athletes to concussions?
If the others should feel free to correct me if they're wrong, but I think we don't really know. I think that there's one thing that I've learned about concussions. We know there's more that we need to know than what we actually do know, especially when you're talking about the younger athletes. Like I said before, I feel like people, what I call sensitive brains. So people with that are sort of predisposed to anxiety, to depression, at least in my experience, seem to do worse. But in terms of kind of picking out who's going to have a concussion, I don't know that we know that. I mean, we do know that returning someone too soon can predispose to another. For example, I think there was a study that said volleyball players put back into volleyball with kind of a suspect ankle are more likely to have a concussion after that. Actually, let me rephrase that. So a volleyball player with a concussion who's put back into early has problems with balance and may be more predisposed to another injury because of that balance difficulty, such as an ankle sprain. But I don't think we really have an ability right now to pick out who's going to get one, and we don't know exactly how they're going to respond, if that answers your question.
So do you think if someone's had a concussion, they're more predisposed to having another concussion, or do they go back to the baseline after the concussion?
Well, again, they're like snowflakes. Everyone's a little different, but I think that what I've read is after 3 concussions, they tend to have a higher risk of future concussions and future difficulty recovering.
Great, thank you. And Dr. McMarlin, so give us your gamut. I mean, you kind of went through what we used to do and what didn't really work, which is we would tell, especially as a team doctor for an NHL team for quite a while, and that's what we did. We put them in these rooms and we said, hey, you just gotta, it's gotta be completely dark and it's gotta be no sensory input. And lo and behold, like most things in orthopedics, I was completely wrong. So what is the gamut of treatment right now, 2021? What's currently trending, and what should we do once we see this athlete who comes in and maybe they have an index concussion or repeat concussion? How do we treat them?
No, so the one thing is making sure or trying to differentiate between a concussion and as Bryan was mentioning earlier, differentiating, did someone have a concussion or didn't? Because just the presence of a headache doesn't necessarily mean they have a concussion. We have a lot of people with neck strains where you get occipital neuralgia, which may not mean you also have a brain injury. There's so many different scenarios that keeping a really high index of suspicion, having any of that gamut of symptoms, that constellation of symptoms we talked about. So we try to maximize sleep. We go through a kind of appropriate nutrition, making sure someone's able to have at least 3 good meals a day, which include, our brain mainly feeds on carbohydrates. So making sure you get, so a ketogenic diet may not be the best thing for someone recovering from a concussion. And intermittent fasting, probably not the best thing for recovering from a concussion. And then making sure we identify early if someone has a significant vestibular balance dysfunction, really doing a strong interdisciplinary approach where you bring in ATC early, you bring in vestibular PT early. If someone has a mood disorder, managing it, because that can dramatically kind of lengthen the recovery if someone has a severe depression. And some of the basic recommendations now, which used to be stage 1 of the return to play, where you get someone doing that light aerobic activity, can treat multiple different aspects of that kind of post-concussion syndrome. So that helps with the sleep maintenance, and it helps prevent mood and anxiety or mood disorder. So anxiety and depression can be beneficial. It's thought that it probably helps with our dopamine levels. So getting a light impact, low exercise, and obviously if someone has a balance disorder, they're going to need, you have to be very specific that you can't go out on your mountain bike going through the woods if you have a vestibular disorder. So kind of very individualizing the recommendations. And also really communications, supremely important. So talking with the guidance counselor and vice principal at school, making sure they understand this person had a brain injury. This is not, they didn't just get their bell rung. This is an injury to their brain that takes some management, and to also make them comfortable with the process, that this is not going to be a forever thing. But I mean, the longest or the greatest amount of time spent, I think, especially in the first visit, but is really answering parent questions about what the prognosis for their child is, or for their significant other. So making sure you spend enough time with these people to answer their questions, because if they don't buy into your program, they're not going to do it, and they're going to be more likely to have a tougher recovery.
Buddy, this was excellent, and I really appreciate it. CORA really appreciates it. You guys have a great night, and thank you.